Hello, my name is AnnalisaDalke. I will be presenting my nutrition support case study over acute respiratory failure with hypoxia and hypercapnia related to pneumonia. Here you can see the two different types of acute respiratory failure. In this case of this case study, the patient did have both types of respiratory failures. Now, for the recommendations for estimated needs are very similar to Aspen guidelines. It is recommended if indirect calorimetry is not accessible to use Penn State if the patient is intubated. And then protein needs are increased with respiratory failure as well. Patient information for my patient, for Miss CR. She is a 73-year-old Hispanic female with no food allergies, with past medical history highlighting of congestive heart failure, COPD, on home O2, hypertension, and type 2 diabetes, who is insulin dependent. Day 1 of admission, Ms. CR was presented to the emergency department due to worsening shortness of breath. Upon arrival, she did have oxygen saturations of 38% and resulting in intubation and sedation. My patient did have a diagnosis of pneumonia 1 week prior to coming in, and these are the admitting diagnoses at this time. Patient was intubated and sedated on day 2. We were consulted for 2 feedings. I did get to do an assessment and only saw mild temporal wasting. It was difficult to examine signs and symptoms of malnutrition due to her being ventilated. One thing to note in significant labs is that the FOS was low at this time of the assessment. FOS replacements were ordered, however, they were not given. The hospital that I'm at, we utilize plus or minus 200 kcals with utilizing Penn State to help with the fluctuations of propofol and prevent overfeeding. I went ahead and used the fluid recommendations for CHF of 20 to 25 mLs per kcal at this time. And then I went ahead and chose to recommend Nutrien Pulmonary at goal rate of 30 mLs. I picked the, and plus 6 packets of Bennett protein. I did pick this formula for her respiratory failure. The nice benefit to this is that it's low in carbohydrates, so it does help factor in with her diabetes. And at this time, patient was not on any pressors. Day 3, patient is still intubated and sedated. We are infusing at goal rate. Per ND note, we are tolerating 2 feeds. However, patient does have an AKI, as you can see, with that slight increase of creatinine and her BUN, and as well as her rest of her renal labs. Her intake for the past 24 hours was 300 mLs from when I did the check. On day 4, we were extubated and be able to advance to a clear liquid diet. Day 5, our AKI did resolve, and we did have a bowel movement that day. However, on day 6, we were placed on NPO due to potential aspirations, and G-tube was placed on this day, and a patient is on BiPAP. Unfortunately, per ND note, it did say if to start 2 feedings if unable to wean off of BiPAP. Day 8 was a follow-up. We were consulted on day 7 late at night. However, we were unable to assess until today, and that was due to a failed swallow evaluation. As you can see with reassessing, our weight did increase slightly, and this may be related to fluid retention. Therefore, I did use her first measured weight for estimated needs. I went ahead and continued on with the same formula at a new goal rate to better meet her needs. And I went ahead and advanced her a little bit faster just because we were previously tolerating formula. On day 9, we remain on AVAPs at this day, and the flushes were increased by the MD. As you can see with these labs, it was called for. 2 feedings were still infusing at goal, and on day 11, we did get to move out of the ICU. However, uh, per MD note, patient is confused and combative, and we did pull out our NG tube, and we are now on 100% AVAPs due to worsening pulmonary condition. Day 14 was another reassessment. I did get to reassess this patient and see her. Unfortunately, no family were at bedside. I did get to do an updated NFPE with only seeing mild clavicle muscle wasting. I got to speak to the charge nurse. She reported that SLP had not yet reevaluated, and patient was unstable to get a replacement of an NG tube due to AVAPS dependence. From the previous labs from prior, I went ahead and just played it more on the safe side and decreased her protein slightly to 0.8 to 1 grams per kilogram, just to help with renal insufficiency. However, with the recommendation that of me keeping at the same rate without the beta-protein of the same formula, Nutrin Pulmonary, it does meet about 20% of kcals. I went ahead and did drop her down to advancing slowly, just because we did have a long period of time of not having anything at all. And this is the end of my patient tracking. Here is a slide of my labs. As you can see, that glucose remained high, as well as the BUN and CO2 labs. And here is a summary of the highlights of what did occur within the past 2 weeks of this patient. And then these are my references. Thank you so much. I really appreciate you for taking the time and hearing me with this presentation.